Well, I'm Brian Buchanan. I'm one of the intensivists here at the University Hospital ICU and associate professor. My main interest is critical care of point-of-care ultrasound and ICU and other environments. And I thought I'd talk about kind of pitfalls. Okay, so we're talking about key pitfalls and strategies to overcome pitfalls, reduce risk of bias. Now, I don't have time to cover every single potential pitfall. Okay, just because obviously that would take forever, and I'm pretty sure I would immediately induce a kind of corneal glaze over most of your eyes. So I want to avoid that, but I want to talk about some specific cardiac ones, which I think are things that we can all look at and consider when we're trying to use cardiac ultrasound on the bedside, because there are some key areas. There are a number of papers now that look at kind of pitfalls in this area. Okay, I'm just going to turn my video on here. So this is a paper actually by Ghislaine Duflay, who's an intensivist an anesthesiologist out of Toronto, who's a colleague of mine, who's fantastic, published a series of pitfalls in ultrasound. This is a paper looking at color and pitfalls, color Doppler, and just the issues with kind of valvular regurgitation. And then just a general kind of pitfalls across multiple different organ systems. And then finally, Sam Ward's group, I think he's in the UK, looked at a bunch of pearls and pitfalls in comprehensive in critical care echocardiography. So these are good resources to look at to explore where are the areas that are problematic in this field. And I'll talk about some personal clinical experience, some court cases I'm familiar with, and the focus will be on cardiac ultrasound. So we know that critical illness is often caused, very complicated, by dynamic cardiac illnesses, things that may be part of the problem. They may be a consequence of the problem. They may have no bearing at all on the problem. But of course, you have found it, and now you need to know what to do about it. Practitioners of POCUS, depending on their skill level, may be at risk of misidentifying anatomic structures or incorrectly identifying benign or serious pathology and incorrectly attributing that perceived pathology to be part of the problem. There's also a risk of propagating errors if incorrect details are documented in the chart or an opinion is left in the chart that has been seen to be more certain than maybe it should be. And there's also lots of pitfalls we know about on 2D and with color Doppler and more advanced Doppler. My general feeling about ultrasound, as it is for ICU, is the more complex an intervention is, the more complex an investigation is, the more likely it is to produce an incorrect result. It's just as a general, I think, a general medicine sentiment. Echo can be revered as kind of the ultimate, bedside tool, but just one kind of test. Okay, and I've seen multiple cases. If you're around ICU or critical patients long enough, you see where many times where the shortcomings become quite apparent. LV function is dynamic. EF measurements can be quite variable, especially in shock, and so it's not surprising to see people say, "Oh, the EF is 20% or it's low," and the next day it's 50%, and nothing seems to happen. And people say, "Well, clearly there's a difference in how people evaluate EF," but the truth is that EF can change quite dramatically based on a number of conditions, things like ventricular loading, adrenergic state, and so on. Even experts can make errors. Over time, there is more and more systems using machine learning and artificial intelligence to look at chamber sizes and do more advanced measurements. These are still have some clear errors. And some concerns are just super thorny. They're difficult for anyone or any algorithm. It doesn't really matter. They're just difficult issues. Okay, valves are one area that are just generally very difficult. And echo is not a surrogate for systolic or diastolic heart failure or shock. And some people, if you don't have a lot of experience in kind of managing or seeing shock, it's very easy to look at a heart and say that's the source of the problem. But many times we know that echo can show us things that necessarily maybe just be a consequence of the problem. Ultrasound in general has a risk of distraction from crucial clinical details. So for some patients, they're in shock and you've gone to grab the machine to look at their heart when in fact maybe your hand should be on their belly because they have peritonitis. Okay, or in fact they have obvious findings of infective endocarditis, or frankly the patient's having a clinical deterioration in front of you. I have seen a couple of patients over the years who have been having an echo at the very time that they've gone into a malignant arrhythmia, like a VF or VT, and I'm sure you have in cardiology too, where all of a sudden you see the echo tech turn, a certain shade of white. And ultrasound is one piece of the puzzle, but it's not the whole puzzle. And so it's really important that we understand ways to combat that kind of malalignment of focus, because yes, it is helpful, but I've had times where I'm convinced that it's going to be a cardiac problem, and lo and behold, it's actually like bronchial obstruction that's just unbeknownst to all of us. Patient had hypoxia. And diagnosing an ultrasound can be a potential benefit. It can also be potential risk, especially if the patient's undifferentiated and your pretest probability is not really directed. Okay, so that's where I think the risk is largely, and it comes to do with experience, comes to do with your pretest probabilities, and comes to do with the complexity of what you're looking at. If people here are familiar with the Dunning-Kruger paper, kind of published in the mid-60s, or sorry, 1996, not 60s. It's not that old. It's a good paper to look at, though, but it really just explores kind of the journey to competence. And as you can see in the bottom there, I thought this was like a really nice illustration, which I thought was hilarious. There's like a mega expert and then a mega supreme oracle of expertise. And then after that's just intermediate, which I thought was hilarious, because that is almost certainly what knowledge feels like, whether it's ultrasound or ICU, just that the more that you collect, the more you feel like the less you actually know. And that's just like, I constantly get questions about diastology. And this is just one area in which I feel like the more you're at diastology, the less you're convinced that it's even a thing. And it's not that it's not a thing, it certainly is a thing, but how we measure it may be the problem. This is my favorite John Cleese statement. If you are really, really stupid, then it's impossible for you to know whether you are really, really stupid. Which I just thought was hilarious. John Cleese is a funny guy. So let's go through some cases here. So this is a 58-year-old male with septic shock from unilateral nephrolithiasis. Gets antibiotic, gets some fluids, he gets a stent, he's recovering, but his norepi is slowly escalating post-stent insertion. The anesthesiologist does a quick IVC ultrasound to determine whether the patient could be fluid intolerant, okay, or fluid responsive. Whatever you want to, however you want to use IVC ultrasound. Here is the image. You're going to describe this IVC for size and collapsibility. I have led you down the garden path. Is that the IVC? Yeah, no, it's not the IVC. It is the aorta. But this is a common one that's described in literature as mistaking the IVC for the aorta. They're both long tubular structures that are essentially paraspinal. But part of what I did there was just knowing whether you knew the anatomy, but also just talking about when you're shown something and said, what do you think of this? What do you think of this, IVC? You're kind of like, oh, it looks, wait a second. Like, let's go back to anatomy. Is that the thing I'm looking at? This can happen with aortas and IVCs. This can happen with right and left ventricles too, where people will go back and say, well, hold on, is that the LV or the RV? And sometimes the probe slipped because of improper acquisition. Sometimes it's because it's a challenge to know which one is the dominant cavity, okay? Depending if the RV, for example, becomes apicalized and then the LV becomes less of the apical chamber. So I'm glad none of you fell into that. Not IVC. Is that the IVC? Good. Excellent. So obviously this is not the IVC. It does not connect to the right atrium. Okay, we don't see the hepatic vein like we see on screen right here. Okay, we also see that it's covered in this highly echogenic material, which is mostly fat. Okay, there's also some free fluid in this one too, and you often will see kind of visceral artery takeoff like SMA iliacs down here. That's your telltale sign. Whereas the IVC is juxtahepatic. It's kind of within the liver essentially. And all the vessels kind of course through the liver for the most part. So first of all, make sure you know what the structure you're looking at. And like I said, make sure it connects to the RA. And this comes back to, whether IVC or whatever it is, look at the anatomy. For example, if looking at the LV, you can say to yourself, does the LV connect to the LVOT? Okay, connect to the aortic valve, connect to the arch. You can draw these things back, okay, to make sure that you know what you're looking at. So that's my first thing is fight back to emerge to immediately identify versus characterize. And, perhaps you can imagine why when a echo tech or, echo or a ultrasonographer is at the bedside and someone's like, what do you see? What do you see? What do you see? And you're like, hold on, like, let's, give me a moment to actually think about what I'm looking at, because it's not always obvious, whether that's cardiac or non-cardiac ultrasound. Case 2, 45-year-old male who presents with shortness of breath and hypotension, requiring intubation and vasopressors. Okay, so here's your image. What is a key pathology shown on this clip? Perfect. So this is a challenging clip. Okay. I think the next slide has another. Okay, so here we go. So this is what kind of view is this, everybody? Long axis, right? Yeah, perfect. So that's left ventricle, that's left atrium, that's mitral valve, aortic root, RV or RVOT more specifically. The pericardium is around here. So what's this space here? Pericardium, nice. And what's this space here that's outlined with this white? Pericardium. What's this space here that's with the red drawing around it? I think I heard plural, right? Okay, yeah, good. Excellent, plural. Okay, so there's both. That's what we've established. Now, I will say that it can be actually quite challenging to determine for some patients whether you're looking at plural or pericardial or both or one. So the big thing is to use multiple views, okay? And you can also look at the chest, like with lung ultrasound, to look to see if they have a pleural effusion, which can help a lot. But it's not always that simple. So here we go. Here's the just reduced depth. I just wanted to show that if you do not adjust the depth initially to see behind the heart, okay, or kind of below the heart, then it's very easy to miss, for example, that there is this big amount of anechoic space behind the heart. So, if you miss this up here, okay, anterior to the RVOT, you might miss the fact that there's actually pleural or pericardial effusion at all. Versus on this one, it's, pretty obvious that there is this big space back here. Okay, so what do we think about the LV function here? Normal, abnormal, depressed, really depressed? Yeah, it could be hyperdynamic, it could be normal-ish, probably more views, right? The RVOT, is it open? Is it closed? Does it look normal? Yeah, it looks pretty normal, right? Looks like maybe there's some collapsed during systole, which would be called systole, of course. Short axis. What do we see here? Yeah. Fusion there, right? Yeah. LV function here. This is the levels of the mitral valve. Okay, so this is the typical bagel and croissant formation, right? Bagel, croissant comes around. Okay. Okay. Now, here's an image. What compartment is most likely displayed in the anechoic space in the near field? Okay, the near field is the top part of the screen. Well, so this is a really interesting one. Okay, it's actually pleural space. And it's really hard to tell here. Okay, I can guarantee you that. And I feel like these kinds of images are generally just hard to interpret. Okay, but the pericardium is around the heart. Okay, and it's actually, there isn't a lot of effusion here. Okay, but there is actually a pretty large pleural space. And if you move the probe a little bit over, you can see that there is actually lung contained in this space. Okay, so this is actually the pleural space. But again, this is like an easy fake out, right? A very easy fake out. Now, looking at the chambers, what do we notice? If our thinking like is, could this be tamponade? What are we thinking about? And this is just showing that if you place pulse wave Doppler for mitral inflow, that there isn't a lot of inflow variation. Okay, so this is just one way to look at pulse wave Doppler measures flow at that site, and we're just saying that the flow towards the probe there, this is what's called the E wave. Okay, although there's no ECG gating here, but there's not a lot of flow variation. So given what you've seen, are you worried about cardiac tamponade? Yes, no, maybe, I don't know. Good. So most people have said no here, and 2 have said maybe. I think that's entirely appropriate, and I don't know is also appropriate. Pericardial effusions can be quite challenging, okay, because for a variety of reasons, which we'll go into, it may not be that obvious. And there's like classical tamponade where patients have like the echo findings, they have pulse paradoxus clinically, they have elevated jugular venous pressure, muffled heart sounds for what it's worth. But there's also a whole group of patients who don't actually follow that same script, and it's actually not as obvious. Now, in this case, we didn't see any indicators of pericardial tamponade. If I see an RV and an RA open, if the IVC is partially collapsing, I know the venous pressure is probably low. There's not a lot of obstruction to infilling of the right side, then it's probably not really the issue, okay? Because tamponade really is an obstructive filling defect. But while there's no tamponade here from pericardial effusion, okay, be aware that there's lots of case reports, a plethora of case reports that describe basically tamponade-like effects from a large pleural effusion. Okay, so these are, I've had cases before too where patients are in respiratory failure, and the thought is, well, we'll just intubate first and then stick a chest tube in for the pleural effusion. And you just know that if you in fact sedate them, lay them supine, that actually, if you see a drop in their venous pressure, you might unleash the tiger. Okay, so generally, I don't like large pleural effusions, especially if they're, new or lateralizing, for example. Then I get quite concerned that if you drop their blood pressure, you might see some significant issues upon induction. But yeah, lots of cases where pleural effusions can be a source of problem. So I guess the first point is it can be difficult. Again, you can look at the chest itself, like in the mid-axillary line, to see if there's a pleural effusion. The one thing I would caution you is just because you found it does not mean it carries great clinical significance. Those cases where I found where patients don't have tamponade, but they almost certainly have an infected effusion, okay, that's different. Not that common, I would say, but it certainly does happen, especially with things like Staph aureus. At time A, it may not matter. At time B, it may matter much more. I've seen my fair share of patients who have benign pericardial effusions and then get brought in the operating room and get given a bunch of propofol and fentanyl and paralyzed, and all of a sudden they go into tamponade, because tamponade is just a delicate balance between pressures that are in the pericardium itself and pressures in the ventricle. So, and certainly you can reverse that. Okay, you can give fluids that can increase the intraventricular pressures. That way they are no longer tamponade. It's a good explanation for why, if you have a patient who's in tamponade, especially if it's more like the kind of chronic pericardial effusion that comes in, that if you give fluid to, you can see that those hemodynamic effects, both clinically and on echo, they can reverse in the course of a pretty short time with fluid bolusing. But the big problem with finding anything on ultrasound is this term called search satisficing. So once a diagnosis is found, the search is called off. Another idea of bias is premature closure. So once a diagnosis is made, the thinking stops. Okay, so these are problems that we know about that are in ultrasound in general. The radiologist is aware of this. The cardiologists know this is a problem. So at the point of care, it is important to be aware of things like your pretest probability, what's your post-test probability, and how much it's changed your perspective on the diagnosis. And frankly, if you're just uncertain, no need to hang your hat on it. Maybe call a colleague, call a cardiology and ask them for opinion, which is always valuable to have another person weigh in, another person with lots of experience. Another false positive pericardial effusion here. Okay, so there's the pericardium around here. This is a pleural effusion. This was a case actually from Anton's, where Anton trained from London. So that's lung that's shown here. Okay, so very easy to have a fakey anechoic space at the apex. If you think about the apex itself, that checks out. It makes sense because it's just part of the chest. There we go. Okay, so here's a real one. Okay, this is a case we had that arrived here in extremis that my colleague, Dr. Brizubois, did a bedside perc drain. So a lot of duress in this one, but we drained it and there's a pretty bloody effusion. But yeah, so just be aware these are real possibilities. But there's other problems too. Okay, this was a patient we had with pericardial cardiomyopathy who was aggressively diuresed over the course of 3 days for pulmonary edema. And was really having a lot of troubles. And then my colleague asked me to come echo the patient because they were going up on norepi and looking a bit worse. And so I did the echo and I thought to myself, what am I looking at? Like, I'm for sure looking at atrial inversion. I can barely see the RV. Okay, it's tiny. The LV is obviously dysfunctional. And there's obviously more complex hemodynamics going on here. When you look at the IVC, and the IVC is not plethoric, it's not dilated, it's actually kind of flat and collapsible. So anyone know the term for what this problem is called? It's not common. Oh, it's on here. Volume-dependent tamponade or low volume tamponade. So this can happen if you have, especially if you have isolated pericardial effusions on the right side and you aggressively diurese them. You lower their intraventricular pressures to the point where the intrapericardial pressure is higher. causing dynamic collapse. And you will see they have low volume. The IVC is flat and collapsible. Whereas generally, the IVC carries actually a really high sensitivity for ruling out tamponade. So generally speaking, if the IVC is flat and collapsible, it's most likely not tamponade. This is the one case where it certainly could be. But the other issues, for example, the RV has hypertrophy or there's pre-existing pulmonary hypertension, then you actually may not see RV collapse until pretty late. Okay, and by late, I mean they may be on kind of death's doorstep pretty quickly by the time that you decide to drain it. So be aware there's lots of caveats as per usual in medicine. So like I said, patient with cardiac tamponade may have display the typical cascade of diastolic collapse if they have elevated right-sided pressures. There's other issues that have been pointed out, again, back to those papers. If you see severe atrial dilatation, mitral stenosis, or paradoxical septal motion, these may indicate that you have, high right-sided pressures, for example, especially if the right atrium is massive and you think to yourself, maybe there could be some right-sided volume of pressure overload, and that may confound your assessment. Again, another reason to involve our colleagues in cardiology and just get that overlap to make sure that we know what we're looking at, because it's very easy to close and say it's not the problem, but cardiac physiology can be complicated. Any questions on that case at all? So that case was not tamponade. That was just a big pleural effusion with a relatively smaller pericardial effusion. Okay, case 3. 47-year-old female with severe burn injury, 70% total body surface area burn. So this is a fairly large burn. This is a real case. Within a few hours of the admission, the patient kind of has blown through the Parkland formula because of critical hypotension, basically escalating doses of pressors. Gets 10 liters in the first 4 hours, which is pretty dramatic. So about 4 to 5 liters over where they should be. And they're just kind of looking worse. I don't know why this is going so slow. There we go. This is the first image. Okay, there it is. And then we'll go to the next image. This is a short axis now, parastomal short axis. Refractory shock in this burn patient. Based on the images, what are you worried about? Dry, yeah, hypovolemia. Okay, good. So far everybody is, I think, probably the majority feels this is low volume. Obviously, hemorrhage fits in that. Obstructive shock and SAM are also two themes that have been mentioned. I think that's important because in your illness scripts of managing worsening shock, obstructive shock should be on that list, including SAM. Okay, so that definitely should be on there. So actually, let's just go back here and just say, what do we see in this image first? You see the right or left? That's what I thought you said. Yeah, both right and left are probably underfilled to an extent, right? Really low volumes, okay, like tiny low volumes. You can't really make out the cavity all that well in systole, which is generally a problem. Is there a pericardial effusion? Yeah, there is, right? Do we care about it? Probably not, but we can look at other images, other clips in different planes. And maybe there's some consolidation here in the far field. Short axis now. I think this would confirm what we've already mentioned, really kind of underfilled, hyperdynamic left ventricle. The RV is barely seen. It's not really a croissant. It's more like a, I don't know, a Twizzler, if I can use food terms. It's very small. This is awful, this leg. Okay, here we go. So yeah, very, very small chamber volumes. Okay, and given this story, hypovolemia is up there, which I think most people pointed out, but some people pointed out that maybe there's something else going on here. Okay. For those who pointed out what else is going on here, what does this view demonstrate? Nice, yeah. So when it comes together, it does this, right? Whereas a normal mitral valve should just do this, open, close, open, close, open, close. It's instead being pulled to one side. Now, like I said, even if you didn't have the images, this is something that should be on your differential. Okay, so even without echo, like refractory shock and systolic anterior motion or dynamic obstruction is the umbrella term, should be on your differential. And that's important because it may impact how you're managing the patient. Okay, so yeah, there is some SAM here. Okay, there is, like even on 2D, we can see this valve is kind of fluttering in. the base of the septum here too is maybe a bit bulky, and the cavity volume is very low. Okay, and low cavity volumes are the typical setup for a dynamic obstruction scenario. In both chambers, again, very small, as we talked about. No color, some color here now. So I've added some color. And what does the color show us? Yeah, excellent. So the blood flow here is speeding up. For those who are maybe less familiar with color Doppler, it's blue away, red towards. Okay, so if you surpass the velocity, the blood's heading from here down through the LVOT. So if you surpass the velocity in this direction, then you'll get color mixing, okay, or mosaic. So blood here is speeding up. That also gives us a sense that clearly there is acceleration. Another thing you can look for, as I talked about earlier with the ultrasound group, is that sometimes what you'll see in posteriorly here is you'll see posteriorly directed mitral regurg, okay, because the leaflets don't coap properly. Okay, I didn't show that slide here just for the sake of keeping it on time. So that's accelerating. And now we can see, look back to our 2D image, that kind of makes sense. Okay, we kind of zoomed in here. As we can see here that again, anterior leaflet, that's one close to the aortic valve, is kind of fluttering towards, okay, and that typically causes issue with coaptation and the flow acceleration through the LVOT. And here's the IVC for what it's worth, which in this situation is not necessarily worth that much in a ventilated patient. So this is a severe burn injury with a seemingly refractory vasoplegia and large volume fluid resuscitation with hyperdynamic ejection fraction, flow acceleration, and aliasing and stalk anterior motion. This is, if you're just going to say, I've had probably literally 4 or 5 patients who are just like this, whether it's TTE or even transesophageal, where we're, doing an echo, wondering what's really going on with the patient. But this patient would be on already quite a bit of norepi. And what can be the issue with norepi? Inotropy, right? It's not, yeah. So it's not just the impact on the vascular resistance, okay? It's also the impact on inotropy. So that patient did have a fairly bulky basal septum, and with lots of inotropy and a reduced cavity volume, that's also like the pitch spike setup for dynamic obstruction. Okay, so that's the situation where you want to get them off norepi and slowly get them onto more of a pure alpha agonist. Okay, so onto, say, phenylephrine. And also you got to increase the cavity volume. Now that's actually really hard in these patients, in burn patients, because they just can be very, very leaky, okay, and have very leaky capillaries. And so I have some cases where, they've required an extreme amount of fluid, like 20, 30 liters in the course of, 8 to 10 hours, because they're just so profoundly dry and so profoundly leaky. And it's really hard to make that cavity volume any bigger than it is. I'd say it's frequently underrecognized. Everyone thinks that the most likely thing that this happens from is hokum, okay? But the truth is actually that of cases that I've seen in here, I'd say 90% are not hokum related at all. Okay, they either have a thick ventricle or they have a bulky septum, what's called a sigmoid septum, or they have a funny aortic root angle, creating a sigmoid septum, or they just have another reason why. Like, for example, Takatsubos can have apical akinesis, which causes a bit of basal hyperkinesis, which can be near the septum, base of the septum. So there's lots of reasons why someone can have dynamic obstruction, and certainly hokum is not necessarily the one that we see the most. Severe hypovolemia or regional hyperkinesia, as I mentioned, with or without inotropes can lead to this problem. We know too that high heart rates, okay, so if you drive a high heart rate, then you'll have reduced diastolic filling, and that also reduces cavity volume. So as part of the way to manage dynamic obstruction is to try to slow them down. So things like IV esmolol can be used, although most people, their sphincters typically tighten when the idea of IV esmolol is vouched. You can't make a diagnosis you're not aware of. I just thought this was hilarious. I'm not sure this is real. This is like New York Post. I think it's real, but it's also hilarious. So I don't know if anyone here diagnosed dog or panda, but in retrospect, it's obviously a dog. So yeah, if you're not familiar with this condition, it can be hard to diagnose because as you saw, like the 2D findings are quite subtle, and color Doppler is just technically challenging. Again, here are the factors that really set up for this condition of dynamic obstruction in general: reduced preload, reduced afterload, okay, septic shock or vasoplegia, just low, basically states where they have zero vascular resistance, tachycardia, reduced diastolic filling, and some LV hyperkinesis. Okay, this can happen as a consequence of medications, of conditions, and large anterior MIs where the base of the septum is preserved can try to compensate for the lack of function distally. Again, Takatsubos, cardiac, post-cardiac surgery. These are all issues that can cause this kind of basal LV hyperkinesis that's right near the outflow tract. But there's other problems too. This person had 4 liters off on hemodialysis because they were thought to be wet. And they became bradycardic and arrested on dialysis, and then were brought down to ICU, and we were told that they needed more fluid off. Obviously, you could not get more fluid off if you tried. Literally, you'd have to squeeze them. It's just not possible, right? So, but this is weird. This is a different one than just Sam. This is where, because the LV is not a bag. It's not just like a bag of muscle that like gets blooded and then squeezes. It's like more like a circuit, right? And in that circuit of the left ventricle itself, you can have what's called a mid-cavitary gradient, where as the blood tries to squeeze through the circuit, the actual cavity is too small, because in this case, it's LVH in a dialysis patient. Okay, so it's so small that actually you obstruct in the cavity itself. Okay, so I truly mean, if you tried to dialyze this patient or take fluid off, they would again probably arrest, because they would just obstruct. And if you obstruct the cavity, then you can't get blood out. So the problem with hyperdynamic left ventricular function, there's a bunch of things that have been shown in the literature. First of all, people can be distracted from right side heart function, which actually is part of the problem. So if you have a big descended RV that's not filling the right side, then obviously you can have an obstructive shock. But some people will focus on the left side and say, well, look, the left side's fine, like it's hyperdynamic. But of course, if you're 100% of almost zero preload, is still zero preload. And this can occur with low preload hypervolemia. That could be hemorrhage. That could be just dehydration, for example, bleeding. I've seen patients who are post-CPR who are bleeding from a liver laceration, for example. Can happen with low afterload, like in cirrhosis, okay, which in this case, fluid administration is less likely the answer. And interestingly, in itself, there's been a couple of cases now where actually it's been associated with higher mortality, just in general. Okay, so it's important to know that a hyperdynamic left ventricle is not just like, oh wait, the heart function's fine. Like it's all good. There's like no problems here. Okay, there's other reasons why, which you get into, but the big thing here is to know that don't conflate a hyperdynamic function with high heart function or high output, because that's just not true. You can have patients who are profoundly dry, for example, or obstruction, as we saw. Also, other problems, severe mitral regurgitation, where they have a low circuit the other direction. Okay, so they actually have a high output, but actually the problem is it's going in 2 directions. Okay, for some reason, there's always cases of kind of high output heart failure. For some reason, this can happen in obesity, which is an odd thing, but there's some idea that this could be related to vasodilatation and adiposity. AV fistulas, that could be through new routes like a TIPS, post-cardiac catheterization by transfemoral puncture, where you actually can create a circuit between the veins and the arteries. Okay, so these are basically high pass or high volume shunts. Hyperthyroidism, acromegaly, and all the rest of them too, right? There's a whole bunch of other kind of high output heart failures where, in fact, the issue is not that the issue is not of low output per se, but this can eventually lead to low output. This is a case where, sure, the heart function looks great. Okay, the heart is squeezing well, no big issue here, of course, but obviously with color, we know that there actually is a big issue. And I'd speculate that you don't need to be a rocket surgeon to understand that there's prolapse here, or that the valve does not look empirically normal, but I showed the color here just to show how obvious this was on color. So severe MR can make a ventricle look like it's more functional than it truly is. Just some other examples where, like on 2D, the valve obviously is not coapting, is flail. Okay, here is prolapse. Tons of MR going back. So just be aware that, again, hydrodynamic EF, they have MR, they actually are not putting out that same volume forward as they are backwards. So again, back to this case, severe burn injury with seemingly refractory vasoplegia and large volume resuscitation, hydrodynamic EF, full acceleration, eliciting the LVOT, and systolic anterior motion. So we changed patient from norepi to phenylephrine. We gave a ton of fluid. Okay, and then eventually we did give some esmolol as well, just slow the rate down. Okay, but this is a very challenging problem to both to diagnose, recognize, and then intervene on. But hopefully after seeing this, everybody here knows that this is a potential bias in using echo and finding this particular heart problem. Questions on case 3? Okay, case 4. This is an interesting one. So this gentleman here is 66, and he came in acutely short of breath. He apparently binged on a bunch of alcohol and stimulant drinks, as one does. Came in with some chest discomfort, some hemoptysis, is not doing great. And it's not really clear what's going on. The idea is that maybe he's just got a lateral pneumonia. It's just, aspirated. Seen by cardiology, the thought was that probably, this is a large consolidation mass. Troponins going down. Bedside ultrasound, not really glaring, well-pushed abnormalities. IVC was nearly flat. RV was small. They don't think it was an ACS. Once he recovers, let us know. We'll sign off. Okay, and here's the parasternal lung axis. This is the mitral valve, aortic valve. Okay, so this is just what's shown at the point of care. Obviously, this is not spectacular windows, and that can happen, right? If you're doing a point and shoot and taking a look and seeing if you can find anything that's, again, a glaring abnormality, maybe you're just doing something very quick. But in this case, this does not look overly impressive. However, again, the limitation is that it's not a great view. And I will say, like, they also said that, you should get an echo, of course, like get a comprehensive echo, because this is just a point of care ultrasound. So I'm not saying that cardiologists not do their diligence, but obviously this is did not seem to be primarily a cardiac problem. So a CT was done. The thought was no evidence of PE. Okay, there is diffuse bilateral interlobular thickening, some maybe moderate interstitial edema, mild atrial enlargement, and the right lung does not look good. Obviously, it looks terrible. Findings are non-specific, may represent pneumonia, asymmetric pulmonary edema, aspiration, or hemorrhage. And there's a small right pleural effusion, okay, although it's, as you can see, it's tiny here. And marked background central lobar, lobular, and paraseptal emphysema. So, at this point, like, really not any closer. And the thought is, like, what is going on? Like, something is very odd here, because as it happens, the X-ray doesn't change. Okay, patient on antibiotics, nothing changes. Okay, and something is wrong. So there's the X-ray again, 3 days later. And the thought is, this just looks so distinct. Like, one side is just so obviously uniformly different from the other side. Okay, so TE time. So here is a mid-esophageal four-chamber. That's left atrium, that's close to the probe, left ventricle, right atrium, right ventricle. Okay, and this guy's still like at 90% FiO2. So we felt like this was reasonable given that he was still not doing great. Now we know the chambers. Is there anything we see here that catches our eye? Okay, left atrium looks big. Although I will say, like, on in the world of TE, left atrial size is not always the best because it's too close to the probe. The valve, prolapse. Okay, so maybe there's some prolapse. It's not right here, right? It's like something's wrong. Okay, so idea of maybe flail vegetation. Great. Okay, let's put some color on there. Oh, look at that. Bang. Can you see that louder for the online audience? Nice. Looks like someone over here has just slam dunked on this valve problem. Okay, here we go. So this is the anterior leaflet. This is the posterior leaflet. Okay. You can see here that this valve is prolapsing significantly, arguably probably a bit of flail here. Okay, there's a lot of movement here. Okay, and there's this valve, this color is really compressed, almost smeared along this portion of the atria. Here again, we can see this is a esophageal long axis, left atrium, left ventricle, aortic valve, aortic root. And what we can see here again is this is very anteriorly directed. Okay, so it's with that posterior leaflet here. So it's very, very leaky and letting blood in, which is spilling contralaterally. And again, very eccentric. There's like preferential flow, regurgitant flow towards the one side. Yeah, yeah. There are other causes of asymmetric pulmonary edema. They're just like far less common. I think pulmonary vein stenosis is another one, which we don't like. I think I'm more likely to see that like in congenital than you are in adults. But knowing that you can see here that this is the posterior leaflet. And it just like we don't see it in plain here because it's not actually coapting. And interestingly, they took the patient from here to the cath lab to get their coronaries checked out. And here's an LV gram. And something odd happens here. Cardiologist, interventionalist said basically that they could see the regurgitation into the actual pulmonary veins, sorry. So, and if you look closely, I don't know if it displays all that well here, but you can actually make out the pulmonary veins in the upper portion here. It just is pretty subtle. So lots of regurg. So the problem with MR, there's lots of problems looking at mitral regurg. But here is the Nyquist limit. Okay, this is how we detect aliasing or changes in flow and speed. And so here is a lower aliasing velocity than this one. So once you surpass this velocity, you get color mixing. And what we've done here is we've raised the Nyquist, and this has reduced the signal overall. Okay, reduce some of the noise. But you can raise this, if this is raised too high, you minimize the true signal. Okay, you can make it look smaller than it truly is. So generally in the heart, unless you're looking at the atrium, usually you're kind of between 60 to 75 or 60 to 70 centimeters per second as your Nyquist limit. If it's too high, it'll minimize it. If it's too low, it'll overemphasize it. So people classically talk about jet area, which is like how big the regurgitant jet is. And that's one area that is, we know, recurrently problematic. Because if you not adjust your Nyquist limit, you can make it look far bigger than it truly is. And in this situation, it's actually it's a bit more subtle, okay? In this case, if we look at concentric mitral regurg, so this is the atria here, and this is my poorly drawn valve. Here is blood flowing into the left ventricle, and then here is regurgitation going backwards, okay? So if it goes straight back, it's called concentric. And if it goes straight back, then that's good because it's aligned to wall with the Doppler beam. We know that, color works best if we're not 90 degrees to the pattern of flow, okay? But what if your color jet is like this or this, okay? Instead of going straight back, it actually wraps around one side or the other. What happens to that velocity or that perceived velocity by the machine? It's less, right? It's less. And if we're relying on aliasing, then we're just going to see less aliasing, right? So that's one problem. So these jets often appear smaller than they are, albeit this one wraps all the way around to the back. And generally, if it does that, it's probably an issue, okay? But the problem here is these jets can appear much smaller, okay? And there's this weird thing called the Coanda effect. Here's a super nerdy physics video. Just go on YouTube and search Coanda, and you'll be spellbound for about 12 minutes of action. A cardboard cylinder and this weird thing that detects flow in the background. And he's blowing air, okay? And he's going to bring this column of air down on the cylinder and watch what happens to this big column of air, okay? Rather than having this big distal jet expansion, it kind of wraps around. The same effect works on airplane wings and helicopter blades and what have you. But in ultrasound, it has much to do with eccentric flow, okay? But here's some mild central jet, here's severe central, and here's severe eccentric, okay? See how it looks smaller? Because you get this compression. There's less aliasing. It looks less impressive, right? But trust me, it's impressive. Now, on TE, it's different because you're behind the ventricle now, or you're behind the atria now. Okay, so you will see things differently, and your angles are different too. So you will have a much higher sensitivity for that kind of issue. And this is often talked about vena contracta, which is, as the blood drains backwards during systole and creates this regurgitant jet. This is the neck of the jet. They call this a vena contracta. Here's our jet expansion we rely on for jet area. But of course, in eccentric MR, okay, or eccentric valve problems, it'll be compressed way off axis. Okay, so it may not be as obvious. So here's concentric versus eccentric. And this comes back to how the valve leaks. Okay, this is a more complicated schematic on how the valve leaks with reference to what the valve problem is. Okay, I don't want to go into great depths here, but the issue is that the valve can leak whether it's stretched and leaks in the middle, or if there's perforations in the leaflet, which it leaks eccentric ipsilateral. If the valve prolapses, it can leak contralaterally. Flail, it can leak contralaterally. Thickening, it can leak ipsilaterally. Anyways, there's a lot here. I don't want to go too much into this. And this comes back to what the problem is. Okay, is it a primary valve issue or secondary issue? Secondary issues being far more common, things like ischemic ventricles that dilate the annulus and then leak centrally, okay, versus issues that cause kind of lateral papillary issues or valve issues, for example. So this patient, basically unilateral infiltrate, the POCUS echo was unimpressive for a significant MR, had significant eccentric regurgitation, much more obvious on TE. So caution with valve examinations on POCUS. That also applies to endocarditis. The reason why TTE has limited sensitivity, it's between like 50 and 70% sensitivity, is because it really depends on the quality of the exam or quality of the windows, but also what the actual problem is. So remedies, obviously part of this round is part of the remedies to being aware of what these problems are. Things like picking up SAM and hyperdynamic ventricle, our patient with a pericardial effusion with or without hemodynamic complications, or for example, looking at valve problems. Okay, I would still say, like, while I don't use stethoscope routinely, I think it's still useful to auscultate for cardiac valve problems, and obviously use your colleagues in cardiology because these things get pretty thorny. And just be aware that the more complicated your intervention is, the more likely you are to produce an erroneous result if it's not your area of expertise. Be mindful of Dunning-Kruger. And you know, training in general relies on an adequate volume and adequate case mix of exposure. Longitudinal supervision with the archiving and storage and quality assurance is critical to reducing the chance of errors. Okay, and that's all I have for now. I think